Okay, while we're waiting for a few more people to log on, I thought I would just go over a little few details for today's webinar. My name is Dr. David Kunashko. I'm the medical director here at BioFlex Laser Therapy. We are a photobiomodulation medical device manufacturer for both professional and consumer line of devices. And we've been around for, gosh, well over 30 years now, and I've been here pushing 15 years. I am a chiropractor and I've been practicing for well over 30 years, and I specialize in laser therapy, or what's really referred to now as photobiomodulation therapy. These webinars I tend to do two a month. One is specifically a little bit more, how shall we say it, in depth, which is what I'm doing today. And that is geared more towards healthcare professionals, given their background, but also focusing more on our professional equipment, although these are complementary and anyone can watch and tune in. And then I also do a line of webinars on our consumer grade of devices, our P120, P180, mini port home, those kinds of things, and specifically more how to use that equipment at home to treat some of these conditions as well. These webinars are always recorded, so if you want a link to the recording sent to you, then just register, even though you can't make it, for example, that's fine. You can just register and not show up, and you should get an email within a week or so of the actual webinar, a link to the webinar. If not, then eventually they are uploaded to our website under support, so you can look for them there as well. So today's topic, obviously, I mentioned earlier, is treating sciatica with BioFlex laser therapy, obviously a really common condition that healthcare professionals see in their office every day. So I thought I'd go a little bit more in depth about sciatica and how laser therapy can be very helpful, amongst other things, to treat sciatica. So I'll talk a bit about the definition of sciatica. It's an interesting term, so I'll go over that, and then a little bit about the anatomy, and then specifically into some of the causes and symptoms of conditions that cause sciatica, and then of course how laser therapy or photobiomodulation can be helpful in healing this type of problem, and then specifically how to use your equipment for treating sciatica. And there's always time at the end for questions and answers. I'm going to say if you have any questions along the way, just type them in, put them in the chat box. I'm having problems with the question box for some reason. I don't know why, but it's not working. It has been working for a while. So we'll stick to the chat box for communication. It's a little bit easier that way as well. So sciatica neuralgia, or sciatica, is defined as pain in the distribution of the sciatic nerve. No kidding, due to an actual pathology of the nerve itself. So something's going on with the nerve to cause the symptoms. It's a form of radicular pain and is described as a disease of the peripheral nervous system. Thing about sciatica is that there's some confusion with it. I mean, patients often refer to it. Us healthcare professionals, we may kind of use it loosely to our patients, but we all know that it's kind of an acronym, a little bit outdated term. Oftentimes, it's just used to describe any pain down the leg, but it doesn't necessarily mean that that's a cause by the sciatic nerve, right? So it could be referred pain from something else or what have you. So when we talk about sciatica, really what we're referring to specifically is something to do with the sciatic nerve and along its pathway. So any condition structurally impacting or compressing the sciatic nerve obviously can cause sciatica symptoms. The most common causes, I'm sure we're all aware, is bulging or herniation of the one or more intervertebral discs. In older patients, though, it tends to be more things like degenerative conditions like stenosis that oftentimes cause it, or other things like spondylolisthesis can also cause sciatica, which is obviously a misalignment of the vertebral bodies. And then other things like, we've all know about piriformis syndrome or muscle spasm or inflammation around the nerve itself that can cause sciatica like symptoms as well. And of course, the more serious types of conditions like tumors and masses and hematomas and abscesses, anything that can potentially put pressure on the sciatic nerve can cause that as well. So you need to make sure you rule that out when you're doing your good thorough history. So it does have some unique epidemiological characteristics, including that there seems to be no gender preference. Usually it's female more than male. That's usually how it goes. Um, but in this case, it doesn't seem to be that way. The peak incidence is in patients in their fourth decade. And this is interesting. The lifetime incidence is anywhere from 10 to 40%. So that is, you live to 80 years old, you have up to a 40% chance of getting some sciatica. So yeah, it's pretty common. The annual incidence rate is 1 to 5%. There seems to be no association with body height, although there's kind of an increased association. If you're taller, you might have more potential for a sciatica, especially as you're older. That's great. Since I'm about 2 meters tall, I'm looking forward to getting sciatica. And it rarely occurs before the age of 20, unless there's trauma involved or like, tumors or something of that nature. So it also has perhaps some genetic predisposition, as most things do. Physical activity increases the incidence in those with prior sciatic symptoms and decreases in those with no prior symptoms. Obviously, there's probably occupational predisposition, depending on what you do for a living. We all know those kinds of jobs, especially like driving, right? That's a real common denominator for these kinds of issues. Anatomy wise, again, I'm not going to spend a lot of time. We all know the sciatic nerve is from L4 to S3, and we all know if they all fuse together to form the sciatic nerve in the pelvic cavity. We know the pathway. We've all learned about that from our education. It leaves the pelvis. Once it goes through the sciatic foramen, and then it courses through the inferior and anterior to the piriformis. Of course, we know the piriformis can be a problem in this as well. And then behind or posterior to the gemelli, obturator internus and quadratus femoris. Then the sciatic nerve enters the posterior thigh and courses down, and where eventually it branches into the tibial and common fibular nerve. Just in case you forgot, here's a nice little picture to show you that pathway, the nerve roots coming out, and then you can see the sciatic nerve popping out underneath the piriformis, and then posterior to the gemelli and obturator internus over here, and then you can see it going down your leg. It's actually, it's funny enough, as practitioners, we all think, okay, we know where everything is and all that. But when was the last time you kind of reviewed your anatomy, or especially superficial anatomy? That's really important for laser therapy, is that when you're using a laser probe and you want to hit the sciatic nerve or hit the piriformis or nerve roots or whatever, those markers, those superficial markers, and understanding where you are is going to make your treatment more effective. So, even though you probably know it, or you think you know it, or maybe it's been 30 years, like for me or whatever, reviewing it is also a good idea as well. Some of the common causes of sciatica, herniated lumbar, lumbosacral discs, those tend to be the most common kind of scenario. Usually it's a lateral herniation like L4, L5. That's going to cause L5 radiculopathy. If it's really lateral, then it might touch on L4. And we all know that the straight leg raise test at, less than 70, less than 60, it really triggers that. Of course, imaging is going to be helpful as well if you feel that's necessary. And, this little diagram to show you where that sort of weakness of the disc is on the lateral side, and then you get pressure, compression of the nucleus pulposus through the torn annulus fibrosus fibers. So we all know that. Spondylolisthesis, which of course is forward translation of the vertebrae, and this can cause narrowing at the slips level. In severe L5S1, the L5 nerve root is most commonly affected at the central and lateral recess stenosis, whereas foraminal stenosis results in L4 nerve root compression. The AP films, lateral films, lateral flexion extension films, X-rays, that is, they're going to be helpful in diagnosing that condition. And, schematically, diagram-wise, we all know the grades from 1 up to 4, and it's measured on X-ray how severe that is. Man, grade 4, I don't think that's going to be a fun thing to have for sure. Spinal stenosis, this is narrowing of the vertebrospinal canal and lateral recesses that leads to compression of the nerve roots, and then obviously sciatica-like symptoms. multiple factors, I just mentioned like a herniated disc or epidural fat deposition, hypertrophy of the PLL or ligamentum flavum. These have to be picked up on imaging, like an MRI or CT, hypertrophy of the facet joints, those kinds of things is what's going to lead to spinal stenosis. I've treated a lot of patients with spinal stenosis over the years, and especially with laser therapy. Well, it's a tough condition. It can have dramatic effect and be really helpful. I've seen it help patients that literally have stenosis as soon as they ambulate and they walk, and it can make a big difference. But it's still a challenging condition to keep it at bay, right? So this is definitely a really tough condition to treat, especially when it's advanced. Here's an example of the deterioration of the vertebral bodies and facet joints, and that's when you get the narrowing and the stenosing going on. And of course, things like, muscle-related issues or inflammation of muscles around the sciatic nerve, like the piriformis syndrome. This is a kind of a common cause of sciatica-like symptoms. And it's oftentimes due to overuse injuries. You see in runners or endurance athletes, and usually anything that can cause irritation or inflammation in and around of the piriformis muscle may cause problems. There are ways of testing it, like the Freeburg test and the FAIR, which is flexion, adduction, internal rotation maneuvers. And this can kind of help diagnose the piriformis syndrome as well. So just in case you forgot where the piriformis muscle is, we all know where that is. You can see here. No, there's sometimes anomalies with anatomy, right? The sciatic nerve can actually pierce the piriformis. Those kinds of issues are not really. Yeah, that definitely can be a problem, but it's pretty rare. And the only way to tell for that is to have imaging. Funny story though, I'll tell you one thing where imaging is so important, especially like MRIs, that kind of thing. A good friend of mine, he was having lots of like thoracic outlet syndrome issues, and I kept telling him, there's something going on with that area. And he had several ultrasounds, and the doctors weren't really, they were just kind of saying, no, it's like a non-issue or whatever. Finally, I always say, I hate to tell you so, but I said, get imaging done, like get a proper MRI. He did, and they found this really rare ligament. Oh, now I can't remember the name of the ligament, like Stever's ligament or something like that in the arm, and it basically crosses over the thoracic outlet and can compress it. And that's what happened with him. And why he got symptoms now compared to when he's younger or whatever, I don't know. But it just goes to show you that these anomalies or whatever, like, the imaging is going to really be helpful there. So sciatica obviously includes unilateral pain. Typically, it might be paresthesia. There may even be some motor symptoms if it's severe. So it can appear with or without motor deficiency. If there's motor deficiency, then that's obviously a lot more serious, and you really have to make sure that doesn't progress. And I'm going to talk a bit about that if you're treating a patient that has some motor issues as well. Pain is usually worse with flexion of the spine and twisting and coughing and those kinds of things when you're increasing intrathecal pressure. And the pain is usually quite intense. Like if you've not had sciatica, of course, you've treated patients that have, it's bad. Like it's burning, heaviness, tightness, nerve-like pain. Not a whole lot of fun. And we, of course, know the distribution pattern of the different nerves that might be involved. And of course, you're going to check for specific paresthesias, perhaps other problems, reflexes and any signs of atrophy, that kind of thing. So you're going to do a good thorough examination. Again, just a reminder, this is a little quote that I found. Whoops, I'm going to back up a bit there. From an article on PubMed, is the lifetime incidence can be up to 40% of the general population. So if you want to get out there and get new patients, doing a little, info session on treating sciatica, especially with something novel like laser therapy, is a great way to get new patients into your office. So it's just, something. And by the way, if you're ever interested in using some of my slides, that kind of thing, I never mind sharing that with BioFlex users. Of course, if you're using another laser therapy device, I'm not so apt to do that. But if you're a BioFlex clinician, then I'm happy to do that for sure. A little bit of research. Now, this one is an animal model one, but it's really interesting because they actually look specifically at sciatica in rats or mice or whatever. And it was done by Shimon Roshkind. So I actually know Dr. Roshkind. He's a researcher out of Israel. and probably one of the preeminent scientists and researchers with respect to photobiomodulation and nerves specifically. So in this particular paper, what he was quoted as saying is that there's been extensive, research out there, and that 80% of experimental studies show that laser phototherapy can help promote peripheral nerve repair and at least a positive outcome. He was also quoted as saying the restoration of the injured peripheral nerve prevents progression of muscle atrophy process and allows functional recovery. And he says, however, restoring functions in the case of long-term peripheral nerve injury is still difficult. So the name of the game here is to treat as quickly as possible and try and prevent any long-term damage. This particular study looked at an experimental peripheral nerve crush model, and they looked at three areas, triple areas where they were treating. This is clinically relevant. I'll talk about that as we go along. And those three areas are the actual injured peripheral nerve, in this case, the sciatic nerve, corresponding segments of the spinal cord, and then any muscle involved, right? So just to back that up, if you're treating sciatica, you want to treat around the spine. You want to treat the exiting nerve roots. You want to treat the sciatic nerve, and then you want to treat where the sciatic nerve innervates, especially with respect to the muscle, right? So that's what they're talking about here. They use 780 nanometer wavelength. This is important because near infrared is by far the one that's going to penetrate the deepest and have the best effect. And that range is 780 to mid 800s. Yeah, you can go up to 900 and pushing it, that kind of thing. But historically, and what the research says, and I always have this challenge when people say, oh, what about, 1080 or blah, blah, blah. And it's like, look, this is what they've used. This is what the experiments have shown. The research shows near infrared, 780 to mid 800s, and probably 810 to 840 is about the best, but it's not like 780 is not going to work. That's okay as well. But if I were to choose, I'm going to choose in the low 800s. That seems to be the most effective. And they treated either with 3 minutes long irradiation or 7 minutes long irradiation, or they had a control group where there was no irradiation. So this is the rat, or mouse. I think it was they were using rats. So L4, L5. They actually have L6 in rats. I didn't know that. And then it forms a sciatic nerve. So you can see they treated the nerve roots. Then they treated where they did the compression. So they did a physical compression, peripheral nerve injury site. And then they treated the innervated muscle that area innervated. And so what they found was that the amount of energy delivered to the rat, it was rats, affects total nerve regeneration. The triple treatment irradiation of 780 nanometers for 7 minutes was more effective in promoting total nerve regeneration than the 3-minute irradiation. I thought that was pretty interesting. Just a moment here. So further laser phototherapy significantly decreased the atrophy of corresponding muscles. And the triple treatment irradiation was found to preserve muscle from denervation, and the 7 minutes was shown to better preserve this than the 3 minutes. So in general, longer treatment times up to a certain maximum is more effective than shorter treatment times. Again, a really important clinical point, because sometimes clinicians in their busy day don't want to do things that take a little bit longer time. And I get that. The problem is it takes a split second to do an adjustment as a chiropractor. Okay. It's not a split second to do laser therapy, right? So it takes longer. And the idea here is that if you have hands-free equipment, that's what BioFlex is, except for the laser portion of it. That's going to do a lot of the treatment, so you don't need to worry about that. And then when it's the hands-on, it's only like 4 to 5, 6, 7, 8 minutes in total. So it's not that time-consuming. You can even have an assistant do it as long as they know their anatomy. The clinical takeaway here is that you want to directly treat the source of the injury, treat the innervated muscle. You want to treat the pathway of the nerve if possible, and you want to choose longer treatment times based on the depth of your target. So, if I have a very large person, I might need to treat longer than someone that's not as large, right? That's what I'm talking about. So that's important to understand as well. Another paper I want to share with you, this is a human clinical trial, the effectiveness of low-level laser therapy. That's what it used to be called. Now it's photobiomodulation in patients with discogenic lumbar radiculopathy. It was a double-blinded randomized controlled trial. This is a fairly recent article as well. Let me back up a bit there. So this was out of Iran and Pakistan. So I will tell you this is interesting, is that there's a lot of research being done in photobiomodulation in Iran and Pakistan and India. They have a lot of interest in photobiomodulation laser therapy. It's just interesting that we see a lot of the research coming out of those specific countries. And so in this study, they mentioned that laser therapy seems to modify the inflammatory process and therefore helps painful symptoms related to disc lesions. The modification is brought about by a decrease in nerve conduction. This is interesting because, and I've done webinars on this before, it reduces the axonal flow and the transmission of pain, so it helps that way. It helps to release endogenous opioids for natural pain relief. It increases angiogenesis for helping to repair and helps local microcirculation. And it also has inhibitory effects on the release of prostaglandins, which cause pain, cytokine levels, and cyclooxygenase, which again is part of the inflammatory and pain cycle. And it may even accelerate cell proliferation, collagen synthesis, and tissue repair. So this study was aimed to evaluate the comparative effects of conventional physical therapy combined with LLOT and conventional physical therapy alone. It was a double-blinded trial, and it was at 3 different hospitals. They looked at 110 patients. They all had unilateral discogenic lumbar radiculopathy. Say that fast 10 times, and was obtained through non-probability purposive sampling who had symptoms for less than 4 weeks and confirmed by MRI. Males and females, and mean age of 38. And they randomly assigned into the 2 groups. And the experimental group, the 25 females, 30 males, you can see here, and then the control group. And then the conventional physical therapy was, the McKenzie exercises and hot pack and hold, relax, and sustain stretches, those kinds of things. Here is the characteristics of the equipment they used. 830 nanometers, that's what BioFlex uses. Total output 100 milliwatts. We're actually closer to 200, but we can tune ours to whatever you want. That's another advantage of our software is you can take our laser, it can be 200, it can be 10 milliwatts. And you go, well, why would I want to use 10 milliwatts? Well, what if you're treating something small? What if you're treating a child? There's lots of reasons why you might choose to use a lower power. But you have that option. And then you can see the total energy and all the other parameters. Let's quickly go through that. And laser probe was held stationary on skin contact. Again, another super important point. Almost all clinical research trials, when they're doing laser therapy, they touch the skin, right? So that's really important because most of the energy wants to be absorbed. When you do that, if you don't touch the skin, up to 85% of light can reflect off, which is not great. And it was held, the laser was held 2.5 to 3.5 centimeters lateral to the SP of the involved nerve root at one distal level segment. So again, that's important because you would need to locate where you are, where that nerve root is being affected and to treat that area. Here are the results. If you look at the visual analog scale, group A, you can see it went from a 7 down to a 1. And you can see the next group, which was the group B, which is just physical therapy. You can see it went from a 7 down to a 2. And then you can see the Oswestry Disability Index went from 32 to 17 for the laser group, from 33 to 21 for the PT group. And then you can see lumbar flexion and lumbar extension, again, improved substantially more with laser and physio than just physio alone. So they concluded that the experimental group, which is laser and PT, had produced more improvement in all quantitative variables than that of the control group. So I'm always saying, look, don't just do laser therapy, do the other things you're going to do, but it synergistically helps improve your results, right? So it's like you could say, oh, I get great results. It's like, that's good, but laser therapy will probably make that even better. And it works in a different way than manipulation or manual therapy. So that's why it's really great to add it when you're adding when you're thinking about a treatment regime. So in addition, no major side effects. That's consistent with all photobiomodulation research. No side effects is very safe. So if someone is contraindicated for, say, manipulation, you can do laser therapy, right? And still get a pretty good response. So it's important to understand the depth of penetration of light without going into a lot of detail about it. We know that red light doesn't go that deep, but it really does get a lot of blood, superficial blood, which can have an immunomodulating effect. And of course, the near infrared, as I mentioned, 780 to mid 800s is going to go deeper. How deep? Hard to say. Couple centimeters, 2, 3, 4 centimeters, I don't know. Because it depends on many factors, how much fat there is, the density of the tissue, the skin color, wavelength, power, time of treatment, all these kinds of things. But it can get in there. You should be able to reach a herniated disc or at least a nerve root that where it's inflamed if you know what you're doing. And if you know what you're doing, you're going to apply some pressure contact to the actual skin to depress the tissue to get the tip of the probe closer to the target. So if my target is here where the mouse is, by pushing in, you can see it's closer now. Okay, so another thing I highly recommend is I prefer equipment that has a single tip in order to do this. You can imagine like if you have like a shower head where it's behind glass, and I'll give you an example, like Thor Laser. I mean, it's a good company and everything. I don't have an issue with it, except that they do have a lot of equipment where the diodes are behind a glass plate. And so when you put that glass plate, now there's a distance between the diodes and the skin, so you can get reflection, but even more importantly is you can't push it in. So a single laser allows you to do that much more efficiently or proficiently when you're treating with laser therapy. So don't forget, you got all these muscles in the way, right? You know all your muscles. You have to displace the muscles or push them aside or push into them to allow for the light to get a little bit deeper. So superficial anatomy, okay, you know where L4 was, L5, you're basically going to locate it and go 2 to 4 centimeters on the lateral margins of the erector spinae, and then you're going to push in down towards the nerve root and the inflammation area with the laser probe I'm talking about, right? So if you do that accurately and you get enough dosage in there, you should actually get a really good result over a period of time. Of course, you know where the sciatic nerve lies. It's 1/3 the distance from the PSIS to the ischial tuberosity, and midway between the ischial tuberosity and the greater trochanter of the femur. This is exiting. And of course, the goal here is to be on the lateral margin. So this is the tip of the laser probe, lateral margin of the erector spinae, and you're trying to irradiate in and around where the disc is and in between the TVPs and push in that area. So you need to locate the area that you're doing. If you have an assistant do this, they should know where they should be treating, or you should indicate with a marker or something where they should be treating. I prefer to do this part myself. Perhaps you might as well. Don't forget to apply gentle pressure, and you can even get in a little bit deeper when you're applying pressure to the patient's tolerance. Of course, we do have a proprietary protocol. Now, one of the questions to get asked a lot is, do I need to do all these different placements? And the answer is no. What I recommend is if it's, say, a right-sided sciatica scenario, you want to treat the right exiting nerve root. So that's the bottom one here. And I'm going to suggest you treat over the corresponding spinal levels. So you might just need to do one placement at L4, 5, and S1. That's probably okay. Sometimes you might need to go up a level as well. So that's a second placement. So you got 1, 2, 3, or just 1, 2. And or add another vertical placement just infrared. You can do that as well to get a little bit more extra irradiation in that area. It's a little optional, but minimally 2 placements. This one here, the bottom, L405, or this one here, a mid-level, depending what you're treating, and then the exiting nerve roots left or right, okay? That's what I'd recommend. If you have a dual port um, BioFlex equipment, then you can do these simultaneously. So it's like 12 minutes, right? And then the laser, another 4 or 5 minutes. They're out the door in 20 minutes. So you can do 3 sciatica treatments in an hour, right? And you can bill accordingly as well. So you have a great return on investment by doing this as well. The protocol looks something like this. You can see the time frame. The red is anywhere from 5. You can also adjust this. We have 5 minutes and 5 minutes, 7 minutes and 7 minutes. So 7 minutes red, 7 minutes infrared. That reflects that L4, L5 a little bit deeper. That's usually where the common problem is. I'm going to suggest around that time frame, 7 minutes red, 7 minutes infrared. Above that, if it's not completely affected, you can do 5 and 5. And then the exiting nerve roots, 5 minutes and 5 minutes. Again, you can adjust that accordingly. Initially, a pulse rate of 50 hertz or cycles per second, and the duty cycle is going to be 50%. So about half the power of the equipment is what's coming out. In the laser probe, you're going to want to use that at roughly 40, 50% power, anywhere from 6, 7, 8, 9, 10 minutes. That's variable because it all depends on how long it takes you to treat the different areas. I'm going to talk about that shortly. And then as you move along, when do you go to the next stage? Well, I'll give this, the first one, some time to work. Week, 2 weeks, see how they're doing. Even adjust the duty cycle up a little bit before you go to the next level. So don't treat once and then go to the second level. You'll want to treat at stage 1 for several sessions. If they're responding well, keep it at that level. If they're not responding that great, then maybe tweak up the duty cycle a little bit, maybe even the frequency, keep it in stage 1, and then another few sessions. And if still not seeing great results, then jump to 2 and do the same thing at 2 and the same thing for 3. So the targets for nerve healing and structures involved with radiculopathy, you're going to treat the nerve roots. So affected level above and below, at least one level above and below, but you're going to focus more on the affected joint. You want to get approximately 3 to 5 joules per point. This will vary, but around that area. So if you set it to 42% power, then I think that's around 75 milliwatts of power. Then that should be sort of your starting point. You also want to treat the vertebral disc as well, again at around 3 to 5 joules per point, and then any muscles involved, whether it's a piriformis or anything else that's tender or painful as well. You'll also want to treat the pathway of the sciatic nerve. Again, get 3 to 5 joules in the gluteal region. You can gently push down to try and get that light closer to the sciatic nerve. And then as it's traveling more superficially in the posterior thigh, 1 to 2 joules over the distal thigh. This is also going to be helpful with analgesia and helpful for pain relief as well. And then if it's getting into the muscle, you're having muscle-related problems, you can treat the innervated muscle as well. Using the dual array. The protocol there might be 6 minutes red, 6 to 8 minutes infrared, 50-50, so 50% duty cycle and 50 hertz is what I'd recommend. Whoops, let me back up a bit there. So for example, an L5 radiculopathy, I know we're just at the end point of the lecture. This is obviously a commonly affected area, and we all know the pathway of it, where it's going down and where you're going to have the pain and paresthesia. So we know that the nerve root compression, what can cause that and where it's located. Sorry, guys, I'm going a little bit faster, but we all know the anatomy here. So I'm just going to skip through that. So again, you want to target different areas. You want to target the disc and the nerve root involved. You want to mark the spinous process for reference. Start with lower dosages and then work your way up if need be. And again, I highly suggest you vary the time per point. Now I'm talking about using a laser probe. Start off, with maybe 2, 3 joules or whatever, and then start to go up if you need to, or adjust it a little bit higher if your patient is larger or there's more tissue to get through as well. Again, you just need to think about the size of your patient and the target depth as well. The sciatic nerve, you can vary the time per point according to location. So longer time over the proximal sciatic nerve because it's deeper in the gluteal region and depress the soft tissue within patient tolerance. Okay, and make sure you know how to locate it. Find the gluteal fold, halfway up. Should be no problems finding that. And then if, for example, in this case, L5, tibialis anterior, and maybe you're having some issues there with the motor, then you want to apply the array over that area. You can do it vertically to cover the entire tibialis anterior muscle as well. And again, I suggested 6 minutes red, 8 minutes infrared, 50-50 is a good starting point there as well, too. And you can use a laser probe, start at 75 milliwatts. That's about 42% power and roughly 3 joules of energy. That's roughly total 40 seconds. And you can see if you want to adjust it, if you're using 80%, that's 21 seconds. At 100% power, that's just 17 seconds. So holding it for 17 seconds will give you 3 joules per point. Everyone should know this, by the way. So if I say 1 joule or 2 joules or 3 joules, you should be able to calculate this and understand that because it's really important. And so there's a range of effective joules. There is quite a bit of a range, but if you're too far under that or way over it, you won't see the effectiveness. So typically for the treatment plan, I'm going to recommend several daily treatments. So not like several in one day, but the consecutive daily treatments. So 2, 3, 4, 5 in a row, Monday, Tuesday, Wednesday, Thursday, when they're really in acute discomfort and pain. And thereafter, every other day, at least 2 to 3 times a week until things really start to improve. And you can adjust the pulse rate and the duty cycle as well. Over a period of time, then they can graduate to once or twice a week as they're improving. Total time frame, it's hard to say how long it's going to take, but it depends on the etiology, right? I've seen patients respond quite nicely in a couple weeks and some that have taken a lot longer than that. So that's important to understand as well. One of the things that we do offer is home rental systems at our clinic, and you may or may not be interested in this, is having some of our personal systems where you would rent them and they can do a little bit of treatment at home before coming in, not before, but like in between sessions. This is really helpful just to kind of continuously get the healing effect of photobiomodulation. They don't have the laser probe and the full-blown effect of professional systems, obviously, but it's pretty close and it's very effective. And those of you who are listening in that just have the consumer device, the P120, P180, it's still going to be effective. It just might take a little bit longer. You may need to treat a little bit more frequently with that home equipment. All right, end of the lecture, upcoming events. I do have a couple more webinars scheduled. One is for the consumer line of devices, specifically on light therapy for cosmetic applications, and then a professional webinar later in October. I'm been doing a bit of traveling in October, so I only have one scheduled, and that is, can laser therapy really grow hyaline cartilage? Hint, hint, yes, it can. But it's a great lecture, so hopefully you tune in for that. And we've just announced our masterclass that is on November the 9th. And the theme of this masterclass, I really want to make it clear, is clinicians coming to this masterclass will walk away with new protocols, be able to use those protocols in clinical practice. And the discussions are around case studies, case profiles from our clinicians like Ben Ewan and Melinda Couch, who's a physiotherapist for the figure skaters, the U.S. Olympic figure skaters. Karen Miller, Dr. Karen Miller, a chiropractor in South Africa I've been working with, getting tremendous results. Actually, she combines ultrasound and laser therapy. Of course, Slava Kim, our clinical director, and maybe even I'll say a few words. So this is November 9th. Up in King City at the beautiful Kingbridge Center. If you joined us last time, we had a great event. The food is amazing. The grounds are really nice. So if you can make it out, that would be really great. In fact, it's only, I believe, like $149. So it's on full day Saturday. There'll be giveaways. There'll be all sorts of stuff. You'll be able to see our new equipment. So save that date, Saturday, November the 9th. Get on the early bird and book as soon as you can. We'd love to see you guys out there. And if you need to contact me, David@bioflexlaser.com. Let me see if I can get any of the questions. How many joules per centimeter squared did they deliver? So now I don't know exactly, Janet, what you're referring to there. Sometimes they don't necessarily in the research reference the surface area, so I can't give you energy density. Sometimes it's just in joules, so I'm not sure which one you're referring to there. You might need to be more specific on that one. Let me see about some other questions here. Can laser therapy help with rebuilding bone? It can help with callus bone formation and fracture. And there's some research to show that it may be helpful for osteoporosis. The only problem with that is it's in animal models, not in humans. So it's really a lot more challenging to get light into bones of humans. So, if you're a rat, absolutely. But if you're not a rat, so if you're not like Donald Trump or whatever, oh, sorry, I couldn't resist. Then you may not get the results that you really want for, say, osteoporosis. But there is some interesting research on that. So, but if the bone lies deep, like in the hip, you can't really do it. Okay, I think that's it. That is it. Is the masterclass available on the web? I'm not sure if we're live streaming it or not. We may be live streaming it. I'm still trying to figure that out, by the way. How long is a treatment in sciatica? Well, again, if you're using the professional equipment, 2 placements of the array, that's roughly, I'm going to say 20 minutes in total. With the 2 arrays going on at the same time, if he did that plus the laser probe, 15 to 20 minutes, you'd be able to do that with a dual port system pretty quickly. So that's what I would say for that. Uh, did you hear they're eating cats? And no, I'm just kidding. Oh my God. If you haven't seen the memes on the cats and the dogs in Springfield, just go to TikTok. I couldn't stop yesterday. So they're pretty funny. Yeah. Anyway, have a great day, everyone. Hope to see you next time. And should you have any further questions, you can email me or get a hold of us. If you don't have our equipment, I'm not sure why you don't, give us a call and talk to some of our sales reps or account executives. Take care, everyone. Bye for now.